Well, thank you all for joining us. We're happy that you're here, that we're talking about applying ORP and digital sleep analytics in clinical care with Dr. Magdy Younes, co-hosted by Cerebra and the Center for Sleep and Human Performance. My name is Dr. Amy Bender. I'm the Director of Clinical Sleep Science at Cerebra. I'm going to go ahead and get started because we do have a lot to cover here. So how the rounds works, the way this is going to work if you're new to this sleep rounds, Dr. Younes will present on a new way of looking at sleep architecture using ORP, which provides more information than traditional or standard PSG metrics. He's going to apply this approach to difficult cases provided by the Center for Sleep and Human Performance. And we're actually going to, instead of talking about the cases in the introduction, we're actually going to have Dr. Samuels talk about the cases right before, so it's fresh in your brain. At the end, we'll have 10 to 15 minutes for questions. So if you do have questions, put those in the Q&A box. And then at the end, after the webinar, we will be sending out an evaluation to get your feedback. And also if you have any ideas for future case examples. Hello, there we go. All right, well, I wanted to introduce our speakers for today. We have Dr. Charles Samuels, who is the medical director of the Center for Sleep and Human Performance. He holds an adjunct assistant professorship in the faculties of medicine and kinesiology at the University of Calgary. He is past president of the Canadian Sleep Society and has a clinical background in rural and urban family medicine. He has acted as a primary and co-investigator on over 20 clinical trials and served as the vice chair of the Research Ethics Review Committee at the College of Physicians and Surgeons of Alberta. He has numerous peer-reviewed publications and is a well-respected medical educator, researcher, clinician who speaks internationally on topics related to sleep health and human performance. We also have Dr. Magdy Younes, who is a distinguished professor emeritus at the University of Manitoba. He has been a clinician, scientist, university professor at McGill University, University of Texas Medical Branch, and University of Manitoba, where he served as head of respiratory medicine. Dr. Younes's research in respirology, critical care medicine, and sleep medicine has resulted in over 162 original peer-reviewed papers and 22 book chapters and reviews and numerous patents. Dr. Younes is the inventor of Michelle Sleep Scoring, the Cerebra Sleep System Prodigy Sleep Monitor, and the odds ratio product, the star of the show today. We are very grateful for our speakers for all their experience and expertise in the sleep field with many, 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 many years of experience. And no, I'm not calling either of you old. The topic for today is sleep improvement on CPAP using ORP. So we know that sleep improvement on CPAP is a fundamental driver of adherence and potential outcomes of CPAP therapy. And here at Cerebra, one of our taglines is, let's put the sleep back into sleep medicine. So let's utilize these tools from the polysomnogram. Odds ratio product can allow us to measure sleep at diagnosis and improvement on CPAP to potentially predict which patients may struggle with adherence and require additional resources. So that's kind of the topic for today, is looking at sleep improvement on CPAP. And I'll pass it over to Dr. Magdy Younes, who will go into the presentation from here.
All right, can you hear me?
We can hear you and see your screen. Looks great.
All right. So in previous seminars, we had numerous complaints and threats to kill me because I don't introduce ORP. So this time we'll spend some time telling you the background behind what we'll be talking about today. ORP is a continuous index instead of the stepwise 1, 2, 3, and so on of sleep depth, which is measured in 3-second epochs. And it ranges from 0 to 2.5. And here is the scale. If we use the likelihood of getting an arousal very soon, this is the scale, 0 to 0.25. It's very, very hard to wake the patient up. 2.25 to 2.5 is you're fully awake. And then you have all these grades in between. I just want to point out to you this range here, 1 to 1.75. These are transitional states where you have features of both wake and sleep in the epoch. The green, the first 4 deciles are typically scored by technologists as a sleep, but with different degrees, as you see, of sleep depth. The red ones are typically scored awake, but again, with different degrees, and the middle ones are transitional. They can be scored either way. You might want to ask, why do we need a continuous index of sleep depth? The reason is that the conventional metrics of sleep depth are seriously flawed, and flawed in which way? So here you have, I assume you're all familiar with the conventional scoring. These are 4 epochs. All of them are scored awake because they don't meet the definition of 15 seconds of sleep. But there is clearly a difference, even though they're all awake. This top one is wall-to-wall alpha beta. And the next one, you begin to see some opening with some theta, little theta waves. The next one is a bit more opening, and you can see maybe like stage 1 here and here, but awake the rest. And finally, you get this gross one where you have maybe 10 seconds of micro sleep and 20 seconds of awake. So all of these are called awake, but this one is very, very drowsy, about to fall asleep, and this one is fully awake. And you can see that the ORP tells you the scale of alertness that you are in stages awake. Same thing with non-REM sleep. Here are 5 or 6 epochs. All of them are scored non-REM. The top 5 are scored stage 2. As you can see, the top one is very similar to almost awake, except there's a spindle here. And then it gets deeper and deeper and deeper and deeper, all of that in stage 2. You get to a point where it's almost stage 3, but the delta waves don't add up to 6 seconds. So until it jumps, you can now see that ORP follows that and gives you a scale of depth of sleep within stage 2. And there's very little difference between the deepest stage 2 and stage 3. So this is the fundamental difference between ORP and conventional staging. Now, the question is, how do we measure it? And this is a technical thing, but many people have asked for it. So we do it 3 seconds by 3 seconds. So imagine this is a 3 seconds of EEG. The first step is we do a Fourier transform, which gives us the power in the very slow waves, the next ones, and then the fast ones. So it gives us a number for how big the delta wave that within this pattern. So what do we do with all these numbers? So we do have in our database 430,000 epochs that were collected from numerous PSGs covering the entire clinical spectrum of sleep disorders. So these are clinical data. So we take all the 430,000. So we have 430,000 numbers for delta and 430,000 number for this and this. So we break each range into 10 deciles. So the delta, for example, goes from 1, from the lowest decile will be called 0. The highest decile of delta will be called 9. Same thing with theta and alpha and beta. So this is the next step. Then what we do is to say, where does this delta fall in this range? So we say, okay, we look at where 202 is, and it comes in the second highest decile. So it's called 8. Next, we say, where is the 14 theta fall in the theta range? And it falls in decile 4. Beta is very little, and sorry, alpha is very little, and beta is very little. So you can see now that we have 4 deciles here: 8 for delta, 4 for alpha, 1 for sorry, 4 for theta, 1 for alpha, and 0 for beta. So we do have these 4 numbers. So we give this 3-second epoch the number 8410. So the first one tells you this 3-second epoch has a lot of data, middle of the road theta, and very little alpha and beta. So from the number, you can actually visualize the epoch. The next step is to now that we have 4 digits and 10 deciles, we have 10 to the power 4 or 10,000 different patterns. We take these patterns and sort them from 0000 to 9999. So 00, you can imagine 00 is something that has very little of any frequency, whereas 9 has the highest frequency and highest power in all frequencies. So we have 10,000 here. For each one, we say, how many did we see in our database? For this particular pattern, it was 4,100. How many of these fell in awake patterns or in arousals? And the total then is 40.8. So this 1,700 or 4,200 is 40%. So this is the probability of a 3-second epoch with this pattern to fall in awake patterns. And you can see here, some patterns will be 80%, some patterns will be 0%. So 9990, which is high in delta, theta, alpha, but not beta, would almost never happen during awake. And so then the final step is just to confuse everybody. We divide the probability by 40 because somebody in our team said 1 to 100% is too common. Let's be different. Anyway, so when it is 1, it means that the probability of it being awake is 40%. When it's 2.5, it means almost 100%. So these are some examples. So you can see that these two, for example, have high 9, big delta, as you can see, but they differ from the fact this one has 9, a lot of beta. This one has less beta, but the probability of this happening awake is only 7%. The probability of this happening awake is 100%. So you'll never see this in sleep, and you almost never see this in awake. And the same applies to, so you can see that the number tells you what the pattern looks like, and then the pattern tells you what probability it is to happen in awake periods. And then if you divide it by 40, you get the ORP. I hope now I move to show you the difference in practice between ORP and conventional. So I picked these 2 patients, and this is a hypnogram that you are very familiar with in these 2 patients. And here are the conventional numbers. And you will see that both of them are fairly normal by conventional terms. Lots of total sleep time, good sleep efficiency, just a little bit of N1, quite a bit of N3 and REM, and very normal arousal awakening index. Both of them are normal, so that patient will be passed as a normal sleep study. But if we look at the ORP, you can see that they are very different. This patient is spending most of the time, these are 8 hours, you see in the intermediate range. There is very little deep sleep, whereas this patient is sort of stuck there in very under 0.5 most of the night. There's just the occasional awake period. So you can visually see in this hypnogram the difference, the more information the ORP gives you. Now, if we put these in numbers, because it's very difficult to describe graphs like this, in a comprehensible way, so we put it in numbers. One way to do it is to see what is the ORP when the patient is awake. For example, here, what is the average ORP when the patient is awake? In this case, it's 2.24. This one is 2.02. This is a big difference in awake ORP, and it indicates that this patient has a higher sleep pressure, more sleepy probably. And there is a paper that shows the relation between ORP wake and sleepiness. We look at ORP non-REM. How deep is sleep in non-REM sleep? You see it's 1.34, which is, like I told you, this is very transitional sleep. So most of the time, he is spending time in transitional sleep, whereas this one is 0.4. Most of the time, he is rock bottom in very deep sleep. ORP REM, the same thing. ORP total recording time. So these are very different patients. So one way to express ORP is to say ORP in difference wake, and the higher the ORP during sleep, the lighter the sleep, and the higher the ORP during awake, the more alert you are. There is another way to do it, which is what we're going to be talking about today, is the histogram. So here, this is 1, 2, 3, 4. These are the different deciles, one being very deep sleep, less than 0.25. This is between 0.25 and 0.5. And so it goes until we get to 10, which is 2.25 to 2.5. This is pretty much fully awake. So what we do is epoch by epoch, we count how many fell in this decile and this decile, and then we plot it as a histogram. And when you do it like this, you can see the striking difference between the two patients. This tells you right away that this patient has no deep sleep, hardly any, spends most of his time in very light sleep and transitional sleep. As well, he has very little full wakefulness, which indicates that he is sleepy. On the other hand, this patient has most of his epochs in the very deep sleep and very little transitional or full wakefulness, which means this one may also be sleepy. But unlike this one, his sleep is very good, too good, in fact, whereas this one. So these two patterns, despite the similar conventional numbers, these two patterns indicate very different pathophysiology, which is really what we want to help patient management with by looking at these very simple ways of looking at histograms. Everybody can recognize that. Then we have to then give them numbers, because again, you can't tell people, well, ORP in the first decile was 5 and here it was 7. So you have to classify them somehow. So we came up with this classification. This one is type 1-1. So we came up with a 2-digit number. The first digit indicates how much deep sleep you have. The second digit indicates how much full wakefulness you have. So as you see, 1-1 means he had very little deep sleep and very little full wakefulness. This one had a lot of deep sleep, but also very little. So this digit right away tells you the distribution of ORP in the whole night. You asked me, how did we break down 1, 2, 3 for the first instance? Then we went to the sleep heart health study. We have several thousand people with all kinds of sleep patterns, and we broke the range of deep sleep into 4 quarters and the range of full wakefulness into 4 quarters. So 1 means you are in the lowest quarter of community dwellers in terms of deep sleep. The second here tells you you're in the lowest quartile of full wakefulness in community dwellers. This one, you are in the top quartile because you're number 3 in deep sleep and the lowest quartile. And we are going to then classify people into the different patterns. And to simplify it, we divided them into 9 patterns. So here you see the 3 patterns that have very, very little deep sleep. They all start with 1. But they differ from each other by the amount of full wakefulness they have. So this is 1-1. This one is also very little deep sleep, but has a bit more full wakefulness. This one has the same amount of deep sleep, very little, but a lot of wakefulness. And we will see then that these different patterns occur in different clinical disorders, and they have different associations and so on. This is 2-1, 2-2, 2-3. I think you get the idea now. They have pretty normal amounts of deep sleep, all of them, but they differ in the amount of full wakefulness. And these are now the ones that are in the top quartile of deep sleep, all 3 of them, but again, they differ in the amount of full. So these are the 9 basic patterns of ORP architecture. And these patterns in a paper that was published, which is down here, we found that they are associated with different disorders. They have different association with different quality of life and sleepiness and so on. So they're very different patterns from each other. But these three are the ones that are relevant to us because the other ones don't happen very much in severe OSA. So the next question then is, well, here we go. I'm not going to go through this, obviously, but it's to show you that if you want to know what this pattern is associated with, you can go to this table, which is in the same paper, and you say, okay, type 1.1, it tells you here what is the likely underlying pathophysiology, what are the clinical associations, and what are the functional associations. And so that helps you, understand how different the patterns are from each other. So now we get into OSA. This again is from a study, the same study, in fact, and it's just to show you how the different patterns behave in different disorders. So the first column here is no OSA. There are about 1,500 patients in this study that have neither OSA nor insomnia. And you can see that this pattern happens rarely in people who don't have OSA. And the other patterns, this is the most common pattern and so on. But then we look into obstructive sleep apnea. And the number in bracket is the percent of the group in each category. So this is 2% of 1,500. In mild obstructive apnea, this pattern occurs in 3% of 970. 3% again, 5%, and then you can see how much it jumps in very severe OSA, which is more than 50 AHI. The same with 1.2 and 1.3. You can see that the percent doesn't change very much in mild and moderate, but it starts increasing a lot in severe and very severe, and the same with the third one. So these three patterns are characterized by the fact that they increase progressively with AHI, but particularly with very severe AHI. And the fact the numbers here very similar to no OSA tells you that mild and moderate OSA don't bother sleep very much. So these are the three patterns associated with OSA. And the next ones are the ones with the first digit is 2 and 3. And you can see that their frequency obviously has to go down. If this goes up, so 11 goes to 4 in very severe, 27 to 17, and so on. So these go up as OSA gets worse. These go down as OSA gets worse. We're going to talk about that in another meeting about insomnia. But this is one line of evidence that these patterns are related to OSA. The next question was, well, how do these patterns, if these are the patterns produced by OSA 1.1, 1.2, and 1.3, they should be the ones to respond to CPAP. So this is another study that we are finishing now with the CSCN group, the Canadian group. And as one might expect, type 1.1, every dot is a patient. On average, ORP non-REM goes down, but there is some scatter. 1.2 also the same, 1.3 also the same. The other 6, the number 2.1, it's on the line of identity, so there is no average change in ORP non-REM. And the third one, which has a lot of deep sleep, actually they get worse on CPAP. So that's another evidence that these are the three patterns we should consider to be where the sleep is bad because of OSA. So with these three patterns, as you can see, there is a scatter. Not everybody in 1.1 improves, and the same with 1.2 and 1.3. So we try to narrow it down a little bit, use multiple regression of the response in ORP non-REM against, I think, 10 or 11 variables, and we came up with these equations. So every one of these three types is sensitive to different variables. Type 1.1 is sensitive to AHI, arousal index, ORP, awake, and non-REM, and so on. So every type, but we have these formulas now that if we plug in these numbers, we get the likelihood of improvement of sleep in this type, in each type. And that's how we predict before we do CPAP. So all the predictions we're going to give you are in the diagnostic part of studies, and then we're going to compare it with what actually happens. And this paper is again from where we are working on it now. It should be submitted soon. The other index that is very relevant to this topic is what's called predicted adherence to PAP. And this is another study we did with Pat Hanley and his group to see how ORP influences adherence to CPAP. When we came up with this formula, which means adherence is affected by ORP, non-REM, AHI. So for each patient we're going to discuss today, I'm going to calculate the likelihood of improvement of sleep depth on PAP, as well as the likelihood of adherence. I do have the response to CPAP because Chuck was good enough to give me the PAP study, but I don't have the adherence data on them yet. Maybe he can say, okay, so we want to move to patients, and I'm going to ask Chuck to describe the first patient, JM. Chuck.
Yep, thanks, Magdy. So I'll go fairly quickly. This patient was referred by the family physician with insomnia. And in fact, clinically going through their history, it was clear that they had loud snoring and the high probability of having sleep apnea with non-restorative sleep and restless sleep, which was interpreted by the family physician as insomnia. There was really no clear history of difficulty initiating or maintaining sleep. He's a 44-year-old gentleman with an Epworth of 13. And otherwise, you can see the remainder of the history. And from our perspective, we felt he had a high pretest probability of having sleep apnea, so we put him in the lab. And I'll let Magdy take it from here.
Thank you, Chuck. Okay, I'm starting with this patient because he's sort of your classic patient with very severe sleep apnea that responds to CPAP. I'm going to tell you how these patients look like with ORP. So here is his hypnogram, and as you can see, he's got very severe sleep apnea. His ORP is again right in the middle of this, transitional sleep. You can look at his back-to-back respiratory events and arousal. So he's the classic patient with severe sleep apnea that everybody would expect him to respond to CPAP. And this is now his study on PAP. And at the beginning, they had trouble controlling his apnea, but subsequently, he leveled off, and his apnea, as you can see, went down a lot and arousal. But he got a bit more PLMs, which is another thing that happens sometimes. But what you notice right away is that there is very little oscillations in ORP like he had here. And now, if you look at less than 0.1, he has a lot of sleep with ORP under 1. So that means his ORP, his sleep depth improved, and also the arousal and AHI improved. So then we move on to conventional measures. Still slept a lot, very good sleep efficiency despite his severe sleep apnea, which tells you that not everybody that has severe sleep apnea has low sleep efficiency. N1 enormous, 57%, and went down to 18. But remember that anytime you reduce the arousals, you reduce N1, because every time you have an arousal, you switch to N1 and wait until a spindle appears. So N1 is really a reflection of how many arousals you have. And because the AHI here went from 75 to 27, the arousal index from 72 to 38, but the PLM increased. But I'm just saying that the N1 decrease is really an artifact because of the guidelines. If every time you have an arousal and you have 100 arousals, you're going to get at least 100 epochs of stage 1. And if you don't get a spindle for 2 epochs, you get 200 epochs of N1. N3 increased a little bit, not much. REM increased, and the other ones, of course, AHI, they went down as expected. So looking at the convention, how many of you say he improved? I mean, we have sleep efficiency went down. N1, which is not very good. N1 went down, which is good. N2 is neutral. N3 went up a little good. So some things go up and some things go down. And what is really the net effect? And that's the problem with conventional metrics, is that some go in the right direction and some go in the left direction. And we are left with, we don't really know whether sleep is better or worse. So let's put his histogram here. And here's the classic 1-1, almost no deep sleep and almost no full wakefulness. So, as we discussed before, if there is very little deep sleep, it's either because he has very little sleep pressure, or he has a disorder that prevents him from getting into deep sleep. So if we look at now that, you see, if he had a disorder of low sleep pressure to explain this one should have been up there. So that means here he has high sleep pressure along with low deep sleep. So the interpretation is this is a disorder that prevents the patient from getting into deep sleep. And as a consequence, he has high sleep pressure, which is what you would expect from sleep apnea. And now we look at the hypnogram on CPAP, and you can see there is a clear left shift in the histogram, a lot more deep sleep, and nothing much. There is very little transitional sleep, as you can see here, 10% instead of 20%. So there was a clear shift, but it's not really that impressive. So let's look at the ORP values. The nice thing about ORP is that there is only one way to interpret it. ORP awake means more vigilant. ORP non-REM up means light sleep. So no equivocating here. So we see that ORP awake didn't change very much. ORP non-REM went from 1.16, which is very light transitional sleep, to decent sleep. ORP REM also went down, and ORP total recording time went. So clearly his sleep improved. But now we do the predicted equation for 1.1. So we plug in what the variables required here, and we come up with the value of minus 0.24. So the equation told us that in this patient, ORP non-REM should go down by 2.24. But this is not, I mean, it is average for OSA patients, but some patients go down 0.5, 0.6, 0.7. And so this is not really a dramatic response. But what I want to show you is that what actually happened is that it went down minus 0.29, which is 1.16 or 0.87 from 1.16. So it's not really that different. So the prediction here was okay. Then we do the adherence index, and we came up with 3.26, which means that the probability of these patients sticking with CPAP is 54%. I don't know what I actually adhere. Do you have it, Chuck?
Yeah, excellent. Yeah, so this is the second time I've seen that patient in 15 years, and he refused CPAP the first time and did poorly 15 years ago. And this year he's 100% and doing very well.
But that doesn't mean that everybody like this will be adherent. 54% means it's just a little bit more than 50%. Many people with severe OSA still don't adhere to CPAP. So this is the first patient, and just to start out with a simple case, so that just so you know that our predictions don't goof off when you have a patient that you expect him to improve. Second patient, CR. Chuck.
So CR is a 58-year-old male referred from the Operational Stress Injury Clinic, which is for veterans, and the RCMP. And all of these patients come with severe PTSD. and they're always referred with query OSA because the psychiatrists there are very good at screening the patients. So he was a snorer with no witnessed apnea, non-restorative sleep, and of course he had insomnia, and typical of psychophysiological insomnia and insomnia associated with a patient who has PTSD. His BMI was in the area of class 1 obesity, and the remainder of the history you can see his Epworth was 7, and his ISI, there was modest improvement over time with behavioral therapy from 23 to 21, which actually is really not much improvement at all. Take it away.
Okay, thank you. So this is a patient with a complex psychiatric history, which complicates life. But so let's see how we do in a patient like this. But other than the fact that it's a complicated psychiatric history, it's a common practice for sleep doctors. I was one of them, to put people on CPAP when their AHI is not very high, but they have symptoms, like insomnia or excessive sleepiness. And this patient, obviously, with this psychiatric, he must have some sleep complaints. So that was probably the trigger for doing all that stuff. But we very frequently put people with AHI of 15, 20, or 7 or 8, just because they say I'm sleepy or I can't sleep or whatever. So here is his hypnogram. Here is his hypnogram without CPAP. And you can see that it looks pretty normal. But he has a lot of respiratory events, and he has a lot of arousals. And he has a history of loud snoring, a little bit of PLMs, but there is good reason to say that his symptoms, that his sleep apnea is causing the excessive arousals, and in fact many of the events were called RERAs. So there is reason to think that his sleep is disrupted by his upper airway problems, and therefore there is reason to think that maybe if we treat his sleep apnea, his symptoms are going to improve. What I'm trying to show you here is that this is probably not a good guess. So here is his study on CPAP. He got a lot more PLMs, but that's not that important because they didn't really have a lot of arousals with them. So the arousal, the respiratory events were pretty much fixed, and the arousal index was gone down. But notice what happened to his sleep. It's much higher now than it is here. So his sleep depth in non-REM went down. I mean, he's in lighter sleep. So now let's look at the conventional indices, and his sleep efficiency went down. His N1 went down a little. It wasn't that high to begin with. And N3 went down, and REM went down. Of course, apnea and arousal index didn't change very much. So again, is he better or is he worse, as far as his sleep? Sleep efficiency is lower, N3 is lower. Is that good or bad? But on the other hand, REM is still good, and I don't know. So it's very difficult to interpret these numbers. So now we put the histograms, and what you see here is this patient is 3-1. He has a lot of deep sleep and very little full wakefulness. And when we put him on CPAP, we had a shift to the right. In other words, his sleep became lighter. He lost all the deep sleep, has virtually nothing here. And all his sleep now is in this transitional sleep, and he had more awake time. So this is a patient who has OSA, mild to moderate, but there was reason to think it may be causing problems, but it turned out that really we didn't gain very much. In fact, if we look at his ORP, we find that his ORP non-REM went up 0.57 to 0.98. His ORP REM went up his ORP total recording amazingly. This is huge deterioration in his sleep quality in a patient with mild, moderate OSA and some manifestations, that it is affecting his sleep. So let's look at the expected change in ORP, because 3-1, they already have very deep sleep. I mean, how can it get better? So there was no prediction of any improvement. And in fact, it may have gotten worse, because I showed you before that type 3 with very deep sleep often get worse on CPAP. And that's what happened. In fact, his ORP on REM did not go down, but it actually went up 0.4, 0.57 to 0.98. So that again shows you the power of this formula for predicting whether sleep is going to improve. So if this patient had a high Epworth, we would say his high Epworth isn't really from his OSA. It's to be better look for something else. Maybe he's not sleeping enough. This pattern is most common in people who are sleep deprived. And the reason I say that is we have the adherence index was also saying that this patient is likely not to adhere. Only 1 in 5 chance of him adhering. Chuck?
Yeah, so the only thing I would add to that, Magdy, is that the study, so the therapeutic study was done on Zopiclone. So it's as good as you could do to get the guy asleep, and we didn't get there. And then the other is he was completely incapable of using the CPAP.
Incapable or capable?
Yeah, incapable.
That's right. So again, we predicted correctly here
Yeah.
that this is what he's going to do. And the reason we say this pattern, so if you see a patient who is sleepy with this pattern, it's not OSA, it's something else. Better dig into how much he stays in bed. Or he may even, we've seen many patients with idiopathic hypersomnia and some OSA who look like this. And you don't predict that OSA is going to help them at all. So, but identifying why he has this pattern of sleep deprivation would be the way to help this patient, as opposed to, I mean, I'm not saying we shouldn't have done the CPAP trial. It's just
No. Well, wait, this is actually extremely helpful to us because this is a common patient that's sent to us. And now we have a model, we're sort of left with clinically, should we put them in the lab? Should we try CPAP or not? Now we have a tool that we can use with some degree of confidence. There may be years of validation that needs to be done, but it would have predicted this, and we're getting a lot more experience. So now often we won't actually try CPAP in someone like this, whereas other ones that come from the OSI clinic where the pattern fits, we will. So it's hugely useful.
Right. So why do I say this is sleep deprivation? We have this study on 200 normal people, young normal people were used for something else, no OSA or nothing. And this is their pattern, which is a perfectly normal pattern. A lot, not very much deep sleep, but most of sleep is down here in the sleep range with a little bit of full wakefulness. And then he was 200, there's 36 hours of monitored sleep deprivation. And you see what happened to the histogram. Now, doesn't that look like this? So when you see this pattern and the patient is sleepy, think of idiopathic hypersomnia or too little time in sleep or whatever, poor sleep hygiene. And these people then will likely respond to CBTI. The final patient, LM, if I can spend a few minutes, not going to take much.
Yeah, so very quickly, a female, so she is 46-year-old female RCMP officer on long-term disability leave. She's quite obese, so she has a BMI of almost 50 with snoring, witnessed apnea, pretty straightforward, but also extremely complicated psychiatric history. And I'll let you take it from there. We're closing in 2 minutes to 45, okay?
I thought we were going to have 10 minutes, but anyway, so this is the baseline hypnogram, and you can see the OSA, but what you see here is a lot of respiratory events, but not as many arousals, which is an interesting thing and something to keep in mind, so that she gets an arousal every other respiratory event. and her sleep is not bad, not going too much into the deep sleep, but here it is. So, and on CPAP, what we see is the apneas and arousals almost disappeared, but the sleep didn't change. Her sleep is almost the same in ORP. So that tells you that this patient didn't really improve despite her very severe OSA. And if we look at the conventional stuff, you see sleep efficiency was very good both ways. N1 again went down because the arousals went away. N3 increased a little bit, REM increased a bit, and of course the arousal and they went away. So again, it's a mixed picture. We don't know what happened. But then we go to the histogram, and this again is 1-1. You see there is less than 10% deep sleep, and there is less than 4% full wakefulness. But why did she not respond then? Because this is the type that's supposed to respond. And like you remember, in this type, we had a scatter. If not everybody got better. And we have these formulas for predicting who, even though she was missing a lot of deep sleep and full wakefulness, but the rest of it was shifted to the left. So she's not as bad as other types of 1-1, which are more like a pyramid. And so let's go now and predict and see the ORP. ORP was 0.91 in non-REM and went down only 0.1. ORP REM, nothing happened, and here nothing happened. And if we do the predicted change in ORP non-REM using the specific equation for 1.1,1, it's only predicting very, very little change in sleep depth. And what we got is minus 0.11, which is 91 and 80. And what about the adherence index? Again, this is predicted not to adhere very well. It's just basically tossing a coin whether she will adhere or not. And I don't know why. So here is, did she stay on CPAP, Chuck?
Yeah, so there's a question too that this speaks to. One of those questions is she totally failed to tolerate CPAP, and we diverted her into the behavioral sleep medicine program. And just so you know, she started out with an ISI of 23 and it's now 11. And according to her clinician,
wow.
So she's had a good response to CBTI, which would be, what we would do based on all of these predictive models now. We didn't have that when we treated her. Yeah.
3 out of 3 we struck out, not struck out. I don't know baseball very well. We did very well in the
exactly.
probability, and you might wonder then why is it that she is 1-1 and didn't respond? So now this is the last slide. Why not much improvement on type 1-1? And here is the formula for type 1-1. And these are the relevant variables: AHI, arousal index, ORP wake, ORP non-REM, and how much above 2.25, sorry. And this, I brought that from the previous slide. These are her numbers in the baseline study. So we are going to plug these numbers then in this formula. Here is the intercept, oops. Okay, got it. And AHI is 71, very high. And here is the coefficient. Arousal index is 39. And ORP awake is quite normal. So she's not very sleep deprived. And ORP non-REM is quite normal. That's why she didn't respond, because she has very good sleep before even the CPAP. And this is how much ORP in here, which is very little. And you plug all this in and you come out saying this patient's not going to respond. So even though she has very severe OSA. Thank you very much.
Thanks, Maggie. Shall I go, Amy, and just answer questions?
That'd be great, yeah.
Yeah, so we'll get to it. I'll just do the one in COMISA. Is there an instance where ORP would lead us to turn to CBTI as the first line of treatment? The answer is absolutely yes. Now that we have more experience, we're going to apply that in directing patients once they've responded, now that that patient, for instance, ISI is 11, she obviously has sleep apnea, she has a BMI of 50, and we have a test, we may well go back and do a trial again.
It also shows you how little complaints of insomnia. 23 is huge, and yet she has no awake time, hardly any awake time.
And now this question's for you, Magdy. How does the prediction model change for CPAP adherence and sleep improvement when using split night studies versus full night? I don't know if you have an
Pretty much
answer.
the same. We have the answer. We're just looking at this now. So the split study gives you pretty much the same information.
Okay. In the first two examples, neither patient appears to be fully titrated, still having DSATs and respiratory events. Would you expect that if they were fully titrated, their ORP may have changed? I'll answer the titration, and then Magdy can answer on the ORP. Keep in mind, these are difficult patients with insomnia, PTSD, so there's a limit to the degree to which you can push the titration, and the techs have a lot of experience in knowing where to sort of meet that middle ground where we can keep them asleep and do the titration versus waking them up with higher pressures. But I'll let Magdy speak to the issue of ORP.
Okay, so the issue of if you improve, this is a very good question, actually, because we are hoping to have online ORP during the titrations, so that we can easily answer this question: is whether any residual DSATs or flow limitation are affecting sleep by titrating, going up a couple of notches, and see if ORP goes down. So, I can't answer your question now unless this experiment is done. So if you have ORP in real time, then you can, and we're going to have that pretty soon, Amy, I think, then hopefully that will be used in the future to titrate CPAP, as well as this ORP can actually implant it. That's Dawson used to say that, implanted in the CPAP machine, so that you can actually get in the downloads what's happening, or if you are watching the output of the CPAP machine in line, you can tell whether any increase in CPAP did improve ORP.
I think, at least in the second case, it looked like there were still events going on. Do you anticipate that there would be an even greater shift in ORP with better titration?
No, because this guy his sleep was absolutely perfect. He can't get any deeper than this.
Okay, got it.
Which is the point, the value of having ORP. It's like, okay, we did our best. We're not going to get any better. And so,
well, I don't think we even can try. Like if the patient has absolutely the deepest sleep possible, how can we improve it?
Yeah. And that's the value of it. Discriminating some of these people from, okay, this guy got sleep, and the other one, well, this is terrible sleep. Now we have something else we can work on, let's say. So I think this is the huge value of ORP. I'm just going to move on. Wayne Thompson has a rather long comment, not so much a question.
Oh, boy.
And it's around PLMs. So let me just answer Jamie's question first. Are these all titration studies? He knows because he gave them to you. Perhaps comparing only the portions of the study where optimal response has been established, so just sections. Also, I think this is a first night of PAP, which it is. Would it be different? So Ontario does things differently than Alberta. So in Ontario, they may put someone on APAP for a month and then put them in the lab where they're accommodated. We don't do that in Alberta. We put them in the lab and get them on. So these are then regional differences. So the question would be, would this data look different after 1 month of acclimatization? And Magdy, I don't know if you can answer.
I don't obviously have this data, but I have indirect data in that Charles Penner, I think many of you know him, he did a study on, I don't know, 70 or 80 people with OSA, and he had the ORP, and he found that on average, these are after 4 weeks of CPAP. Okay, so he repeated the study, so like the Ontario model, and he found that the average reduction in ORP non-REM is 0.2. Oh, sorry, 0.1 something, 0.15. And we got on average 0.25. So when we did split studies, so split studies or single night studies gives us an average of 2.25. And after 4 weeks, it was only 0.15. So if anything, it's moving in the other direction. But we have to remember that the patients that Charlie studied are much milder patients, like the AHI was only 30 and the arousal index is only 40, whereas our patients here are, the average is 70 AHI, and so we expect that our patients would improve better. But it's not like after a month, there is a great improvement over, it's actually the other way around, but that could be because of the different severity.
I have a quick one from Alan Hoffman. He's asking, have you ever done any similar studies with oral appliance or even?
No.
And I didn't think so. So back to Wayne's comment, it is long, Magdy, and it's hard to actually titrate it down, but another reason why PLM index may be higher during treatment section of the split night study is related to AASM rules. During diagnostic, PLM occurs, it's 0.5 seconds before or after or during the respiratory event. PLM cannot be scored or tallied. During the treatment section of the split night study, PLMs can be scored in the absence of respiratory events. So it's really looking at that relationship and do you actually score it or not? And so I'm trying to find a question here. Leg kicks on PAP may also be an indication of residual upper airway resistance or collapse. If the PLMs do not go away with increased pressure, they are independent or a secondary disorder. So I think it's just more a comment. I don't know if you can comment.
Yeah, there are all kinds of practical questions now. I mean, we just came up with this stuff. Okay, it's up to everybody that listens, and they can get the technology to do all these studies. And actually, this is just trying to. We are hoping that people will all jump in and do all kinds of studies because I'm 83 years old now. I can't do anything. Especially Wayne doesn't work for me anyway.
Well, you do a lot, Magdy. Have you considered reverse phenotyping? In other words, start with patients who are compliant with and benefit from PAP, and then go backwards. In other words, and see, and then assess the ORP pattern on the diagnostic study in retrospect.
Yeah, we would love to do that if you have patients on PAP, the good adherence, and you have the pre-PAP, send them to us. We'll score them and give you the results, and you publish the paper. Okay.
Yeah. Do patients with mild OSA UARS differ from those with full-blown OSA?
I don't think upper airway resistance affects sleep that much, because usually upper airway resistance happens in people who are in very deep sleep and have severe flow limitation. That usually means that the sleep is already good enough. And the second patient is actually like that because his events were mostly reruns, which.
Yeah. What is the relationship between ORP and severity of OSA? I think you showed that.
AHI. Yeah, I mean, with increasing OSA, the awake ORP goes down, indicating that you are getting sleepier, and the ORP non-REM goes up, indicating that your sleep is getting lighter. So that is the relation, and it's published in an earlier paper. I think it's called Characteristics of whatever, back about a year ago. So the relation between ORP and OSA severity is very well described in a previous paper. Just check it out. I'm still the first author, and Susan Redline is the senior author.
Amy, you're taking the questions away, aren't you?
I am, because they've been answered.
Okay. Were the sleep studies validated and edited by sleep techs prior to the data being entered into the study, or did you just go with the unedited reports from Michelle?
Well, actually, there's very little difference, but these studies are, I think they are, Sunny, you have to ask Sunny that. I don't know.
Yeah, no, they were actually.
Yeah, but very little changes happen.
No, and we've looked at that, and it's not a lot different.
Mhm.
Yeah,
Just maybe a bit more REM or something like that.
yeah. Minor differences in scoring of events, but they're minor. I mean, oh, okay, I'm not sure what this question is. It was only REM stage changes, Sunny says. That was the only thing that was different.
Yeah.
Yeah. So I think that's it.
Okay, well, thank you everyone for attending. And I just want to thank Dr. Samuels again and Center for Sleep and Human Performance for providing those cases, and Dr. Magdy Younes for all of his expertise in analyzing these cases. We will keep you posted on our next sleep rounds, and take a look out for that feedback and other case examples that you want us to go through. Thank you for your attention, and enjoy the rest of your day.
Take care, guys.
Bye-bye.